So we are most grateful for Dr. Wilcox for presenting this this morning. Dr. Wilcox was a psychologist for 8 years before completing her PsyD in school psychology in 2009. She completed postdoctoral training in clinical neuropsychology, where she practiced as a licensed psychologist until joining the Wilcox School of Education at the University of Calgary. Dr. Wilcox is a registered psychologist in Alberta and a nationally certified school psychologist. And I hand it over to you, Dr. Wilcox.
Great, thank you. Let's see if I can share my screen here. Well, yeah, Julian, thank you for having me today. It's definitely a pleasure to be here. So we have a lot to cover. The information that I'm sharing with you is based on both the book on CBIT, and I put the title there, as well as official CBIT training, but want to have a disclaimer that this is not official CBIT training. So if you regularly work with kids with Tourette syndrome or tics, I would encourage you to take the official training. It is very well done, and it provides you some supervision during your first case. So definitely look into that if you work regularly with kids with Tourette syndrome. So we have a lot to cover today. We're going to talk about the rationale for CBIT, so comprehensive behavior intervention for tics, who's a good fit for this kind of therapy, whether or not it works, the treatment structure, tic symptom tracking, selecting tics to target, functional behavior assessment, and functional-based interventions. So for what is CBIT? CBIT has two primary components, the behavior therapy, which is functional behavior interventions, and habit reversal. So the functional behavioral interventions focus on identifying those things that make tics worse and finding ways to modify them to either reduce the tics themselves or reduce how impairing the tics are. Habit reversal then is the process of giving people more control over their tics by teaching them how to use a competing response. So the main rationale for CBIT is that we do know that these external environmental cues can increase tics, and that also internal states can increase tics. And while we can't control the neurology of Tourette syndrome, we can control some of those internal and external environmental cues to reduce those tics. So that's what we focus on in CBIT. So we figure out what makes tics worse, and we find ways to manage those situations. And then we also teach people individually how to manage their tics. It's really important to understand that CBIT is not a cure. It is a way to manage tics. So it's not going to make the tics go away. We're not going to make people be tick-free forever, but we are giving them more control over the tics so that instead of tics controlling their lives, they're controlling the tics. It's always important to know whether or not or how well an intervention works. So CBIT meets the American Psychological Association's criteria for a well-established intervention for tics, and it's the first line. It's in the first line of treatment guidelines in Europe, Canada, and the United States. So just briefly highlighting one study here around the effectiveness of CBIT. In this study, 9 to 17-year-olds participated in it, and they had a significant reduction in tic severity compared to students who received supportive therapy and education alone. And it's important to note that this benefit continued at 6 months after the intervention stopped. So these are skills that people get that they can continue to use on their own, and they don't need ongoing therapy in order to use them. In choosing to use CBIT, we really need to consider some characteristics of the client and of the clinician. So we need to consider the age of the client's commitment, comorbidities, and clinician characteristics. So for age, CBIT is really intended for kids who are 9 years old and older. So you'll have to use some clinical judgment if you're working with younger kids to see if they would really be a good fit. But kids who are younger than 9 tend to struggle when asked to identify their premonitory urges. So the urge that tells them that they are going to need to tic. It's really hard for them to identify that. And it's harder for them to have the commitment to the work needed to do it. So it's really important to just assess whether or not kids younger than 9 have those two skills and how you would maybe modify the intervention if they don't. The level of commitment for both the client and the parent is also really important. CBIT takes a huge investment of time and effort, and most of that is outside of the therapy time. So if parents and or the child aren't willing to engage in that kind of effort, CBIT's not going to be a good fit for them, and they're not going to find a lot of help from it. As with most disorders, Tourette syndrome has high levels of comorbidity, so it's really important to consider those comorbid diagnoses. So the two that are most commonly comorbid with Tourette's are ADHD and OCD. So this is called the Tourette's triad because they're so commonly co-occur. For kiddos who have ADHD, you need to identify that ADHD symptoms can negatively impact treatment if ADHD isn't managed. So if they're having severe ADHD symptoms, it's probably beneficial to look into medication or other treatment for ADHD and get that kind of under control before using CBIT for the tics. Some other things you may want to modify or consider in working with kids who also have ADHD is to maybe have shorter, more frequent sessions, to maybe have additional separate parent sessions, to try to minimize distractions in the therapy setting, and to probably use more frequent reinforcers than you would with other students. For those who also have OCD, it's really important to take time to dig in and differentiate between tics and obsessions, compulsions, because if the student has both Tourette syndrome and OCD, it's likely that they have both. So one way that you can really kind of tease apart whether or not it is a tic or an obsession compulsion is to ask them what will happen if they don't engage in the behavior. So if it's an obsession or compulsion, then something bad is going to happen in their belief system if they don't engage in that behavior, and they have higher levels of physiological arousal. Where if they don't think something bad is going to happen, but they just get this like itchy kind of feeling that tells them that they need to engage in the behavior, then that means it's more likely that those are tics and not obsessions or compulsions. So again, it's really important to make that differentiation and not use habit reversal with anything that you see as a compulsion. Instead, those symptoms really need an OCD specific prevention therapy, such as exposure therapy. Some other comorbidity considerations are developmental disabilities. So again, these individuals are likely to struggle with identifying premonitory urges. So you'll have to work with them on that. They also require more direction and less kind of openness to what they want to do. They need to be more rule specific, use increased reinforcers, and have more concrete reinforcers. So instead of just getting the points, they probably would be beneficial to have some kind of token that they can hold on to identify that they were rewarded for that. For kids who also have depression or anxiety, it's important to treat the depression first. And if the anxiety is primary rather than secondary to the tics, it's also important to treat anxiety first before moving into CBIT. Additionally, a large minority of kids with Tourette syndrome have rage outbursts. So these sudden, intense outbursts of rage with remorse afterwards. And for kids who have those, it would be important to add some typical supports for anger management in addition to CBIT. So clinician qualifications, in order to use CBIT, it's helpful to be familiar with general CBT principles, to be familiar with Tourette syndrome presentations, and familiar with comorbidities. Additionally, we're going to next go into the treatment structure and the core components of CBIT. So during the initial sessions, you review the rationale for CBIT, the overall structure, use some psychoeducation, create a tic hierarchy, create an inconvenience review, and behavioral reward programs. All right, we've already discussed the rationale for CBIT, so we're not going to go into that right now. But in your first session with client and parents, you would go over that. The core elements are habit reversal therapy, which includes awareness, premonitory urges, competing responses, and functional behavior assessment and intervention. And the additional elements are psychoeducation, relaxation training, relapse prevention, and motivation, which includes rewards and the inconvenience schedule. So we're going to go into these in more detail a little bit later today. But in the psychoeducational component, when you're talking with the family, you really go over again that rationale, the diagnostic criteria for Tourette syndrome, the phenomenology of it, the natural history of tics, the social difficulties and comorbidities, the genetic and neurological basis, and the prevalence. So you would take some time going through all of that with the child and the parent. And we will go into this in more depth in part 2 next month. You also create a tic hierarchy. So you list all the tics that they have, and you would first use the assessment that you did with them probably prior to this first session to start that off. And then you would also rate the severity on a SUD scale for each of them. It's important to note that sometimes you'll see tics that are occurring in that session that they don't note. So it's important to kind of question those and ask about those tics that you're seeing. Then you choose an order to address the tics. So typically you want to do the most challenging one first. At the same time, if that challenging one is if that first one is going to be super challenging, so for example, it's not easy for you to see, or the competing response is likely to be really difficult, it's important that the first one is successful. So there are some cases where you wouldn't do the one that bothers them the most first in order to make sure that they have some initial success. And then you would address tics in each weekly session. And then you'd also go over this tic hierarchy every week. So sometimes you'll need to add tics as they start to occur. In the inconvenience review, you just have the patient list all the things they hate about tics. So how horrible they are, how they interfere with their life, how they make it harder to do homework or engage with their friends. And then you will refer to these specific things on their inconvenience list throughout the sessions as a motivator for the hard work that they are going to be doing during habit reversal. And we have a behavioral reward system in CBIT. And the rationale for this is that we're really rewarding effort, not success. So it doesn't matter if they're successful in anything that they do. What matters is that they're putting in the effort to engage in the habit reversal and the functional behavioral interventions. So they get points for attending, for participating in the sessions, and completing homework. And so you negotiate what that looks like. And part of their first homework is to figure out with their parents then what those rewards are. All right, so digging in now to the functional behavior assessment and intervention. So we use the functional behavior assessment to kind of understand, again, the things that are reinforcing the tics. And then we develop interventions and develop a plan for implementing those interventions. So when we're looking at those factors, the functional assessment, the first thing we want to do is determine factors that make the tics worse. So these could be people, so maybe siblings or certain teachers at school, places, so this could be a school building or certain sports practices, demands. Every time you ask them to clean their room, they engage in tics, or a specific school subject may make them tic more. Situations, so it could be right after school or certain social situations. So through a thorough interview with the parent and child, you kind of dig through all of the different factors that make tics worse. And again, the reason that we're doing this is that we're trying to identify those things that we can control. So we can't control the tics. No matter how much we try to just say, okay, don't tic, right? Kids can not tic for a while, but they can't stop their ticking forever based on that. So we really focus on those antecedents. So again, those places, people, activities, and internal experiences that we can control. And we focus on consequences. So reinforcement in these, I'm using very behavioral terms for them. So reinforcement, positive reinforcement is anything that happens to reward what's going on. So increase the likelihood that will happen again. Negative reinforcement is increasing it because you get to escape something bad. And punishment would be anything that decreases the likelihood of the behavior happening. So in the Tourette's guideline book, there's a story about Billy, and I use this story with the parents to walk through the ABC chart to help them figure out how to identify antecedents and consequences. So in Billy's story, he comes home from school. When he comes home from school, he's super stressed out and anxious. So he goes to watch TV with his sister. So because he's really been trying to control his tics all day, he starts to tic like crazy and he's loud. His tics are loud. And of course, this bothers his sister. And so sister's annoyed because he's interrupting her TV watching. So she starts teasing Billy about his tics because they're annoying her right now. His mom comes storming in, sends sister out. That's not nice. Don't tease your brother, comforts Billy, and lets him watch whatever he wants to watch until dinner. So as this continues, it starts to form a pattern, and his tics get worse and worse when he gets home from school, especially when he goes to watch television. So if we think about what's happening in Billy's story, some of his antecedents are that he's stressed out from school, he's anxious, the time period is after school, and the setting is watching TV with his sister. So if we look then at those things that are reinforcing what's going on, actually, sometimes being teased can actually make the tics worse. So that ends up being a positive reinforcer, even though it's not something that feels good to him. His mom comforts him, and kids like that, right? So even if they're getting to be that tween age and they won't admit it, most kids really like to receive comfort from their parents. And then he gets to watch whatever he wants. So those are some pretty significant positive reinforcements. And then the negative reinforcement is his sister sent away, so the teasing stops. So that negative thing is removed when his sister's sent away. And in this, there are no punishments, so nothing happens that decreases the likelihood of his tics. And tics themselves are actually a negative reinforcement. So kids get that premonitory urge. So again, that tickle, itch, whatever that says, I need to tic. They engage in the tic, and then they get relief from that premonitory urge. And so that's a negative reinforcement, so that, itchy, tickly feeling goes away. And so that's that negative reinforcement. Okay, so when we start to create and practice competing responses, we're trying to remove that negative reinforcement from the tic. So we're disrupting that motor pattern and then also disrupting that negative reinforcement from relief that they get from engaging in the tic. So again, our functional behavior interventions help to control the environment to manage tics. So we try to remove reinforcing consequences. We try to minimize or avoid antecedents and exacerbating situations. And when these situations are unavoidable, because sometimes they are, we try to take scheduled breaks when we can and really practice habit reversal during those times. During this as well, it's really important to educate teachers and others about tics so that they know the kinds of things that they shouldn't be doing and how they can be supportive of kids in their classroom who are experiencing tics. All right, so when we look here at our function behavior interventions for Billy, with those antecedents, for the anxiety, we can teach some relaxation strategies, so some things that he can do to control his physiological responses to anxiety. For the antecedents, he had been watching TV after school in the den with his sister. So we can change the setting, the activity, or the person. So he could watch TV someplace else. He could maybe not watch TV right after school and do something completely different. Or we can change the person and just have him not be with his sister during that time. And then monitor to see how that impacts his level of ticking. So if it changes it, then it was a good intervention that was useful. If not, then we we go back to the drawing board and try to find something else in that situation that we can change to reduce his tics. So the consequences for the reinforcers, the sister teases. So if we use a good antecedent intervention, that kind of removes her teasing him. So we really don't have to then address that. But we could also reinforce the importance of her not teasing and have maybe some interventions for her to reduce the likelihood of her teasing. The next one is mom comforting. So this one's sometimes challenging for people because we're definitely not saying that parents shouldn't comfort kids, but comforting kids when they tic reinforces tics. So really trying to change that pattern to remove comfort from being related to tics. So when kids are ticking, don't comfort them then. So definitely then find other times to give love and affection, but we don't want to give it when kids are ticking because it actually increases how likely they are to tic. After that too, Billy gets to watch whatever he wants, which again, for kids, when one, their sibling is punished, that's super reinforcing. And then getting whatever they want out of it is also super reinforcing. So we don't want to give him that reinforcer. So if we need to, if that happens, we would actually just turn off the TV and have him do something else, like maybe practice his competing responses. And again, his sister being sent away is really reinforcing. So it might be more beneficial for both her and him if she actually stays and apologizes for being unkind to him. And when we talk about these things being reinforcing, it's important to note that we are not saying that Billy is engaging in tics to control or manipulate the environment. He probably doesn't even realize that these things are reinforcing his behaviors, but at a behavioral level, they are happening. So when we're talking about these reinforcers, it's not that Billy, again, is doing anything to go, if I like tic a lot, I'm going to get all these good things. Again, he doesn't even realize it, but we can still change these environmental factors to reduce his ticking. So some examples of interventions that we can use for antecedents. And I listed here some of the common times when kids tic a lot. So bedtime is often a big challenge for them. So some things that we can do is have really firm bedtime routines so that they know what's going to happen and the same things happen every time. And bedtime is a great time to engage in some relaxation practice as well. That can help kids reduce some of their ticking at that time. Car rides is another time where kids experience lots of tics. So we really in there want to decrease any safety risks. So some things that we can do is put child locks on, have the kids sit in the middle seat rather than by a window, schedule car rides during low tic times when that's possible, and use car rides as a time for them to practice their competing response. In the classroom, one thing that we can do is preferred seating. So this doesn't always mean the front of the classroom. It could mean the side or the back or someplace where maybe less people are watching them. After school is another big time. So have 15 minutes of downtime before any demand. So again, let them have some just relaxation before they start to get into things. And TV time can also be a time of increased ticking. So one antecedent for that is to have less time watching television. Some examples of consequence intervention, so things to reduce the consequences that reinforce ticking behavior. One, social attention. So oftentimes people pay attention to people who are ticking. And whether that's good or like positive or negative attention, both can actually increase tics. So reducing social attention can help to not reinforce the tics. So for example, don't tell somebody who's ticking not to tic. That's not going to be very helpful. And again, may even increase tics. Do not comfort the child while ticking again. So this can be really hard for parents because it's uncomfortable when we see our kids experiencing something that's not pleasant and we want things to be better for them. But we really don't want to do that during the tics because that reinforces them. Again, do not laugh at somebody who's ticking. and then encourage peers not to react to ticking. So related to this then goes to that psychoeducation of teachers and peers, so they understand what tics are, why they're happening, which can help them to reduce their social attention to the tics. So and the negative reinforcement is escape. So oftentimes in class, kids will get to leave the classroom and get out of doing their work at that point. So if possible, have them continue to stay in the classroom. If it's too much that they can't, make them take their work with them. So they're still going to have to do their work. Maybe they won't get as much done as you would like them to, but it's important that they're not escaping something unpleasant through their tics. Again, we can remind them to use their competing responses if they are experiencing tics that are interfering. And another one, again, bedtime. They often will come out of their room because tics are bothering them, but having them stay in their room and again, practicing relaxation techniques or competing response at bedtime instead of escaping having to go to bed is more effective because it's not reinforcing those tics. So then you develop your plan for how you're going to implement these interventions. So you discuss with the parents when and how the intervention will be implemented, because we all know that if we just have a plan that we're going to do this intervention, at some point, we're actually not going to do it. It's the same if we're going to try a new workout schedule or something like that. If we don't make a plan, put it in our schedule, engage in some of these really intentional preparation activities, we're not going to do it. So that's what this developing the plan is for. We also want to start talking about potential challenges, right? Because there are going to be things that are going to be roadblocks to implementing these interventions. So it's best if we can kind of come up with what they might be and make plans for how to not let that derail the intervention. Then also provide any training and support necessary for parents to implement the intervention. So maybe they need some more training in one of the things that they need to do, or some extra support to say, yes, it's really okay not to comfort your child when they are ticking, and maybe let's make a plan for even scheduled time when you're going to have some cuddling with them and give them some of that really good necessary input, but not related to the tics. All right, relaxation techniques. They're actually not the main part of CBIT. They're used as a complementary aspect to manage the anxiety. So tics can be anxiety provoking, and when we're trying to do something to change the tics, that's also learning something new is anxiety provoking. So relaxation techniques are an added kind of supportive strategy. So some of the things that you teach are things like diaphragmatic breathing, progressive muscle relaxation, and we'll go into more depth about what these relaxation techniques can look like in session 2. And then the main component of CBIT is habit reversal training. So the first part of this is awareness training. So oftentimes kids are actually not even aware when they're ticking. So we can't teach them to use a competing response if they don't know when they're engaging in the tics. So it's really important to first get this clear sense about when tics happen. So they use some self-monitoring, response description, response detection, and early warning signs. So in self-monitoring, we're really getting them to pay attention to when the tics are occurring. And this is the first step. So it's necessary, but not sufficient. So during this first week, they're not going to do anything with trying to change their tics. They're just going to try to identify when they're happening. So there are 2 components to these monitoring. One is they just generally kind of try to pay attention, but then they have some focused times where they're really going to pay attention, both the parent and the child. So they'll pay attention to then the frequency, time of day or days of week when they're worse, and situations where they're worse. Then we go into response detection. So in this, the patient defines the tic in great detail. So really thinking about every single body part that is involved. Some of them, they're actually quite far away from the actual tic, and then the order of movements. We also look at any sensations, and eventually we will look into the tic signals or the premonitory urges. So the main part on this, it really isn't having this definition isn't the important part. The reason that they really go into great detail about what's happening in their body is to help, again, for them to be able to identify when it's happening. So the more detail you go into, especially where it starts, the easier it's going to be to later use the competing response. All right, so in this response detection and early warning signs, the therapist can even simulate the tic if necessary. Sometimes that helps the student to be able to identify what's going on. And then you start to have a conversation with them and ask them to just lift a forefinger to acknowledge that they've engaged in a tic. And every time they successfully identify that they had a tic, you give them praise for it. If they ever miss one, you just let them know that they missed one. And then eventually you'll move into, after detecting it when it's happening, detect it before it happens and when they're getting the urge to do it. And when you're doing this, you have a conversation with them about stuff that's happened during their week, but it's important for those of you who are more therapists to remember that this isn't therapy. And if you start to get into really paying attention to what they're talking about, you're going to miss the tics. So people who have to engage in any kind of behavior therapy, OTs, if you do assessments where you have to pay attention to what they're doing and what they're saying and writing it down, those skills make it easier for you to do this, because the conversation on this is just kind of the background, because you don't want to just sit there and watch them tic, right? So this background, normal kind of experience, but your main job here is to really be watching them and helping them to identify when they engage in the tics. So then we'll choose a competing response, and there are 3 rules for choosing a competing response. The competing response has to make the tic impossible or at least harder to do. It has to be less noticeable and less interfering than the tic. So it's not helpful if we come up with a competing response, but it's going to draw lots of attention to you or still make it hard for you to engage in life when you're doing this competing response. And it has to be something that you can do anywhere. So think even in the shower, right? So if you're having them put their hands in their pockets, that's going to be a problem in lots of situations where they don't have pockets. Next, we identify the social support coach. So this is somebody who's going to help to reinforce and prompt the student in using the competing response and praise them for using the competing response. So in this session, this first session, you identify the support person. Usually it's a mom. For somebody older, it could be a spouse, housemate, sibling, somebody who's with them pretty frequently. So the support person is supposed to be training and encouraging and not punitive. So especially since moms are often the ones also who give consequences for things that they don't do, like not picking up their room, it's important to put some limits on what the social support person does. So for example, they're often only permitted to give 1 reminder per setting. So at dinner, you get to remind the kid to do your exercise 1 time if they forgot to do their competing response. And we need to really remember that it's the kid's treatment, right? So the parent is there to support the kid, but it's really the kid's job to engage in this behavior therapy, which is why it's important at the beginning to determine how committed the kid is, right? If this is something that's not important to the kid, it's not going to be successful, and you should probably wait until it is important to the kid. And for the social support person, it's important to praise the practice and not the success. So again, if it's not helping, that is not the purpose of the praise and the support here. The praise and the support is really around doing the work. And then we have the reward program. So as I've said multiple times throughout this, CBIT is hard work. And students need often some extra external motivation to help out when it gets hard. So we go back to the point system. They get points for doing their homework. They get points to coming to sessions, and they get points for working hard during sessions. And again, during this week, their homework is to kind of determine what what the reward program would be. So the parent and the child determine what the points can be turned in for. And so these don't have to be monetary. They can be something like staying up later, picking out a family movie. So they can be monetary, but they don't have to be. And usually it's good to have a menu of items. So some small point items and some big point items so the kids can choose like, hey, I need a reward now, so they can use their points and get something smaller, or they can save up their points for something bigger. And reviewing their rewards and how they're doing on working hard on their progress is something that you do every week. All right, so lots of questions I see in here. Let's see if I can go through. All right, so Cassie asked, similar to compulsions, do you ever notice that as one tic begins to diminish, another one strengthens or presents? So yeah, that's part of the normal progression of tics too. They kind of come in waves, they ebb and flow. So sometimes as one gets better, another one pops up. It's not always super clear why they happen, but yes, oftentimes one will go away and one will come and take its place. And then Cassie also asked, does the expression of the tic offer relief to the individual? So yes, so that premonitory urge, people often explain it as like an itch or a tickle. And so then doing the tic makes that tickle or itchy kind of feeling go away. And so they get some relief from that. All right, Sandy asked, so what in Billy's story should his parents have done? I'm not, can you give some clarification, Sandy, on what you're asking there?
And I would remind, thank you very much, Dr. Wilcox. I just would remind anybody, if you do have any questions at this juncture, please to post them on chat. And I have launched the post-webinar evaluation, so please do that simultaneously. And Dr. Wilcox will be able to answer your questions.
Okay. All right, so Lori asked, what's the typical length of the treatments? And I think they tend to be about 8 to 10 sessions. Again, then near the end, the sessions take a couple of weeks in between so that they can start to practice how they're going to handle relapse. And then you check in again so that if there are any problems with how that's working, you can work on giving them some extra reinforcement. And in the main training too, one of the things that Doug Woods had said that he would often then have kids who would come back for kind of refresher ones around times that were going to be particularly stressful for them. So again, kids who would be going on to college, right? They're like, I'm worried about how they're going to kind of come up during college. So he'd have a couple kind of refresher sessions to kind of get them boosted so that they're ready to use their competing responses when they're going off to college. All right, so Jeremy, so some things for competing responses. So for example, lots of competing responses have to do with the face. So oftentimes, so let's say that their tic was like a nose scrunch, right? So a competing response for that would basically be to maybe lift your eyebrows up just a little bit because it's hard to make your nose scrunch when you're doing that. So you can't really scrunch your nose while you're making your face kind of longer. So that would be one example of a competing response, but we'll go into those in a lot more detail next time. All right, so Sandy asks, if you're in your 20s and have had Tourette's since childhood, will CBIT be harder or even work as perhaps tic behavior is too much of an ingrained habit? So CBIT does work with adults too, and typically tics are something that do start in childhood. So adults who are experiencing Tourette syndrome have had it for a long time. And in the training, he had given a response of somebody who had just come to one of his talks and actually taught himself how to do competing responses on his own. He was a surgeon and was in danger of losing his job because tics were interfering with his performance. And he actually just found competing responses and practiced them on his own. So yeah, again, no matter when you do it, CBIT's going to be hard work. Some of the benefits of doing it when you're older is, again, you tend to have a lot more awareness of yourself and your body, which makes it easier to identify when they are, and a lot more ownership. So sometimes kids come in who maybe it wasn't their idea to come, right? But if you're coming as an adult, it is going to be your idea. So much easier to engage in the hard work when it is your idea. All right, Jennifer, so how do you address parent support person training when there are parent-child relational problems and or parent support are invalidating, critical, not emotionally responsive? So yes, I think this is quite challenging. I would suggest that with this, it would probably be better to have some extra support sessions with the parent, and then maybe picking a different support person if that person isn't able to be engaged effectively in supporting the kid. But typically, it's more that parents come from a sense of wanting to support their kid, but taking too much ownership of the process. And because of that, then they come off as being critical and not supportive. So in general, some extra parent sessions around how to be supportive and how to step back and give ownership to your kids, I think would generally be a way to handle that challenge. Hannah, how is CBIT delivered in schools? I don't know of any place where CBIT is delivered in schools, but the general structure of it would be the same. The biggest challenge would be that first session. Really, the parents need to be there. And for younger kids, elementary school kids, I would say parent involvement is important throughout. For older, like middle school, high school kids, we usually give them a choice of if they want their parents to stay with them. So those other sessions could be delivered fairly easy without the parent. But again, I don't know of any schools that use CBIT as a program in them. All right, so how do you manage when the competing response pairs itself with the tic and both start to occur? So there have been questions about whether or not competing responses turn into tics, and the research that Doug Woods shared suggests that they actually don't. So there isn't any evidence right now that when you engage in a competing response, that eventually turns into a tic. All right, so are there any known ways to help kids increase motivation or buy-in in engaging with CBIT? So one of the built-in ways to do this is that inconvenience survey. So again, having them identify all the ways that tics are a problem for them so that can be a motivator. And then also those external motivations. But if the kids are like, you know what, these tics really, I don't really care, it doesn't bother me, then they probably shouldn't be engaging in CBIT, right? So CBIT is to help give them control when their tics are problematic for them. So for kids who are like, whatevs, I don't care, then CBIT probably isn't a good fit for them. All right, would the approach change if the youth's parents were separated and the child transfers for homes, or is there parental discord? So yeah, it would be important, especially for younger kids, that there is engagement with both homes. So again, as the kids get older and have more ownership of what they're doing, it's probably a little bit less important, but especially for the younger kids who are going to need a lot more external supports, that would be really important for them to have some stability across settings. And how does substance use interact with tics? And I do not know the answer to that question. So sorry, Cassie, I can't answer the question about substance use with tics. All right, if the child is not as committed, but the parents want treatment, do you focus your work on the parents? Or how do you let the parent know that it might create more stress? Yeah, so in that first session, it would be really important to get a sense about what the kid wants and if it's bothering the kid. And I guess if you can get at least some buy-in that the kid's like, okay, sure, I'll work on this, it could be useful to move forward. But if the kid's like, no, I don't want to do this, then maybe it would be some more acceptance therapy for parents, right? That I think think sometimes as parents, we do want control over our kids in a way that, you know, we care about our kids and we want good things to happen. And so if we see the tics and they look painful, or we see people not treating our kids well because of them, we can become really invested in wanting our kid to get control over the tics. But as parents, especially as our kids start to get older, we do need to kind of give up some of that control and let them be their own people and make some of their own decisions around treatment. So if the kid really didn't want it, then I would probably engage with the parent and maybe then just focus on some of the functional behavioral things, right? So the parents still can do some control around some antecedents and consequences that can support the tics, but the actual competing responses are really 100% what the kid is willing to engage in. All right, Dawn asks, OCD diagnosis or tic diagnosis? I find it hard to tell the difference. Should psychiatry be involved to ensure proper diagnosis? The diagnosis part on that really is around internally what the kid is experiencing. So that's why those questions about what would happen if you didn't engage in this behavior are really important to disentangle whether it's a compulsion or a tic. So if kids give any indication that something bad could happen if they don't do this behavior, then that's really suggestive of it being OCD. So I would say that any psychologist who is comfortable with the diagnostic criteria for OCD and tics could make that that separation between whether they're compulsions or tics, knowing that lots of kids with Tourette's also have OCD, so they could have both. There could be some things that they're doing are tics and some are compulsions. And if there's any concern about needing medication, definitely psychiatrists would be the place to refer them to support any medication management. All right, and so Project Aspire, I think that was pretty similar. All right, any other questions that you have about this first session? The next session is going to go into a lot more detail about competing responses and relaxation therapy and how you come up with those and implement those. But this was just basically the overall structure about how it works.
Wonderful. Any more questions at all from any of the attendees? I believe there is one there, Dr. Wilcox, another question.
Oh, sorry, I missed that. All right. All right, so Shannon is a parent of a male with tics who's 18, ADHD, OCD, comorbid conditions 2. We were told that up to 50% of kids with tics will lose them around age 18. Is there any data to explain why this occurs? Does this mean that tics can be explained by neurological development? Yeah, so one of the studies that I saw on this suggested that about a third of them, they completely go away in adulthood, and about a third of them, they get better but don't completely go away, and about a third of them stay about the same level of impairment. And there is some suggestion that it is that neurological development can account for some of that difference in how they're and how tics display as kids age.